Blood is basically our life-giving force. It brings to us everything we need and takes away everything we don't need. It is a living organ that, in a blood transfusion, is basically transplanted.
Ladies and gentlemen, please welcome Mr. Dale Black.
Well, welcome to all of you. Do you recall this scene? The bus pulls away, revealing Forrest Gump, sitting on a bench next to a curb. A lady walks up and sits down beside him on the bench, and he asks her, "Would you like a piece of chocolate?" And she just ignores him. But Forrest is undaunted by that. He said, "You know, my mama always said life is like a box of chocolates. You never know what you're going to get." Tom Hanks would not return my calls, and so I did the best I could just then. But in this scene, which you all remember, Forrest aptly describes life, loaded with surprises, some delightful, some downright disagreeable. I'm sure you will understand. Now, the yummy ones are easy to swallow, but the yucky ones are sometimes hard to stomach. We never know what we're going to get in life, and I know many of you know that to be true. And for almost all of us, at some point, this not knowing what you're going to get out of the box of chocolate describes our healthcare challenges, which leads us to fruitcake. Fruitcake is one of those special things that comes to us in the mail or via UPS during certain seasons, and it sounds good. It sounds delightful. Fruitcake, what could be wrong? I remember as a little boy in Indiana, my family getting fruitcake from various places around the country from relatives. But I got to tell you, even as a 7-year-old boy, I knew that something was not right with fruitcake. Now, its makers say it's delicious, but it is easily one of the most disliked cakes in the history of baking. It's dense, overly sweet, and very heavy for its size. It's as if there was a galaxy that was like a cake galaxy that got sucked into a black hole, came to UPS, and they brought it to your house, and it was a very heavy box. Sure, some people, they say they like this seasonal baked goods, but we don't really trust them, do we? And one last question, or a couple more, we'll move on now, and I'll give you the reason I'm telling you this. Why does its candied fruit look radioactive? And how can we make fruitcake better? One suggestion, don't make it. All of this is to make the point that fruitcake might not be what it's cracked up to be. This might apply sometimes to healthcare. And in fact, we'll say it does. And tonight you'll see what we might mean. So with the uncertainty of life, like what you get out of a box of chocolates, and with possible misinformation, like about fruitcake, what do we do, especially in the very important matter of healthcare? Well, get a good doctor and a good hospital. That sounds easy. It's not easy, but it's something we should pursue. Uncertainty and imperfection will still be there. Yes, we understand that. But we must ask ourselves, does my doctor keep up with the science? Does he care about me as a person? Is my hospital progressive? And does it utilize the latest advances? What has been my experience at this hospital or the experience of others? Which is why the Patient Blood Management Program, now in its 5th year, is extremely proud to be affiliated with Yavapai Regional Medical Center. And friends, that hospital is approaching its 75th year serving the community. So we welcome all of you. Many of you have come from distances that are quite great, and some locally. We're glad to have all of you. Thank you for the effort you put forth. Now, with Dr. Schoenman's permission, he was supposed to give a talk tonight on orthopedics. He had a mishap with his ankle. He broke his ankle. with an orthopedic problem. But he asked his partner, Dr. Rich Bassett, who has so kindly, at the last minute, practiced and practiced and practiced, and is going to give this talk entitled Orthopedics and Patient Blood Management, a Joint Effort. Now, he's not next. I just want you to note that as a change in your program. Now, to our program.
Patient blood management is important because of the overarching concept in healthcare, and that's to do no harm. We were taught early on as physicians and nurses, whatever you do, do no harm. So we want to care the best for our patients. Patient blood management allows us to do that by using evidence-based practices and just what's best for our patients.
Ladies and gentlemen, please welcome Larry Burns.
Hi. I'd like to welcome you this evening. Thank you for your time and thanks for coming tonight. The 2017 Patient Blood Management Symposium is the 5th educational symposium hosted by Yavapai Regional Medical Center. And I want to recognize also Yavapai College for their support of YRMC and allowing us to use this beautiful venue tonight. On behalf of over 1,800 dedicated YRMC employees, I want to thank you for being here tonight. Many of you have traveled a great distance to be here, and which is a testament to the work we're doing at Yavapai Regional Medical Center to further the science of patient blood management, not just on a local level, but on a national level and on a global level, as you'll see some of the speakers speak tonight. In fact, Dr. Bruce Spies, a pioneer in the field of patient blood management, has referred to Yavapai Regional Medical Center right here in Prescott as a shining light in our nation for our contributions to this important discussion that we'll have this evening. We're humbled to receive this type of recognition. When we think about patient blood management, it's easy to apply parameters on what we know about healthcare. Radiology is down the hall. The heart program's on the second floor. Orthopedics, we'll hear from Dr. Bassett tonight, orthopedics is around the corner. But in reality, patient blood management is a lot deeper. The work we're doing in support of the patient blood management flows through our continuum of care at YRMC. We are literally hardwiring the principles of patient blood management into our organizational DNA, much like we've hardwired our mission, vision, and values that you'll see on the screen here into our culture at the hospital. We know that our work to reduce unnecessary blood transfusions improves patient outcomes. Heart patients have better outcomes, orthopedic patients have better outcomes, and hospitalized patients have better outcomes. This is how we measure success at YRMC, the outcomes of the patients that we take care of every day. In the 6 years since we launched the patient blood management program at Yavapai Regional Medical Center, we've seen an amazing adoption by our medical staff, several of which will be speaking to you this evening. And also all those that may not be on this, but the entire medical community of Yavapai County has, and across the region, this is evident by the vast amount of literature that is published today on the topic. The ratio currently stands, and one of the things that we really are proud of about the patient blood management system at the hospital is we have a tremendous library of clinical literature telling us that this is the right thing to do. And today, if you look at the SABM website, Society for Patient Blood Management, it's a 400-to-1 ratio of positive studies supporting the science behind patient blood management. I'm proud to say also that we've seen a steady reduction in the use of blood at the hospital. Blood is always available for those that need it when it's necessary, but also when it's not necessary, it helps us that we've reduced the blood that we've used over the period. However, we also know, however, that the blood transfusion can be necessary treatment for some patients. We still prescribe blood transfusion when it makes sense to do so. However, our goal is to eliminate unnecessary blood transfusions by utilizing the appropriate techniques and technology that you'll hear from some of the other speakers tonight. We want our patients to know that they won't receive blood unless it's absolutely necessary. And we want our patients who object to receiving blood to know that we respect that decision not receive blood, and that we're able to honor their request if that's their choice. One more here. Okay. The results are undeniable. Our use of blood projects is declining. Our outcomes are improving, and patients are now traveling to Prescott, Arizona, to receive care at Yavapai Regional Medical Center. And we're proud of that, and we're proud of the program that Dr. Tibby has led us in building this patient blood management program. We're becoming known as the center of excellence in this area, and people are attracted to our community to have the service that we can provide. And so I thank you for being here tonight, and we'll move on. Thank you so much.
My realization that blood management made sense was when I was confronted with patients that, whether by choice or through medical problems or circumstances, weren't able to take blood. And the traditional answer of, well, there's nothing else to be done, no longer was satisfying me. There's a lot of evidence that shows that we have a lot of tools at our disposal. It's a challenging problem, but it can be done. And the surprising thing is there's no change in mortality, whether we transfuse or not, for the most part. We can still treat the patients just as well without a transfusion.
Ladies and gentlemen, please welcome Dr. Alex Chopra.
I want to see my video. Psych.
Hi, my name is Fred Wall, and before Dr. Chapa takes the stage, I would like to make a few comments about the experience I had with him. I had a hemoglobin of below 3, about 3.7 when I came to the emergency room. But however, I had a conviction that I would not take blood transfusion. So that was kind of a dilemma. So here comes Dr. Chapa. And I explained the situation to him, and he respected my desire not to accept blood, and took it upon himself to go above and beyond duty, and worked half the night to secure medication from back east that was designed to build my blood back up to a normal level. So consequently, I'm utmost grateful to Dr. Chapa for the excellent job he did on me, and I'm going to be forever indebted to him for saving my life the way I felt at the time. So with that in mind, again, Dr. Chapa, you have my deepest thanks and appreciation for what you have done.
Okay, good. I think that just goes to show you that when we talk about PBM changing lives, it's not about me coming here every year and showing you slides with numbers. There's actual real people that are benefit from the program. And whereas I can't tell you all the details that make Fred's case so dramatic and special, suffice it to say that there was no other center in Arizona that could have taken care of him. As I sit down and ponder about all the things that we've accomplished in so little time, I'm reminded of some of the challenges we faced that at the time seemed, quite honestly, insurmountable. And now nobody would think twice about it. Nobody would think that this was such a big deal or a big problem, but there was a time where somebody like Fred would have gone to hospice. And yet here he is talking to you. Somebody who bled to a point that science would have said before it's incompatible with life. Hemoglobin of 3.7 instead of 12 to 14, that's impressive. And I think about the culture change that had to come about when Peter Tibby invited me to be in the team that would start this project. My mind drifted because I have ADD, so I really don't remember what he said. But I was thinking about sort of JF Kennedy going, we choose to go to the moon and do the other things not because it's easy, because it's hard. I thought it's actually going to be easier to send somebody from Yavapai to the moon than to change the culture, because it's been ingrained through blood, sweat, and tears in training, and it's so hard to change. And yet here we are, 5 years later, not only having accomplished so many of these things, but also sharing that experience, such that recently the hospital received the visit of some consultants, and when they looked at our program, literally they said, we have nothing to offer except, can you teach us a couple of pointers? They were that impressed with our program. In this time, and I'll share some numbers to kind of drive the point home. Most PBM programs would be happy if they reduced inappropriate use about 15%. We achieved 23% on year one. That is impressive. But not only that, 5 years down the road, I did a random surprise trial. And I pulled out all the patients that presented with hemorrhages that were so severe, their pressure was so low, they needed to be in the ICU. 66% were treated with no blood products whatsoever. From the ones that were, 90% were appropriate, and for the 10% that was remaining, it was a judgment call that could be justified. Numbers like that are not easily found in other places. What that means is that this is no longer a program for a subset of patients that don't want blood products. Rather, this has already trickled down the community at large. And it's the community at large that really has seen the benefit of bloodless medicine. Who was here about 2 years ago when I gave one of my talks? Thank you. For the rest, shame on you. Y'all remember one of my slides where I talk about blood transfusions and how some infections are transmitted that way. We know there's a lot of side effects to transfusions that do not get publicized as easily or as prominently as they should. So having accomplished so many things already, having a presence at the Society of Blood Management, being ahead on coagulation management, even 5 years ahead of the guidelines that told us how to manage some of the hemorrhages from some of the new anticoagulation. Things like that you don't hear in the newspaper because we just go about and do our job. We don't go and look for a pat in the back except when patients pop up and say thank you, you know? And being now the chairman of the committee, I felt that it was a nice point in our history to stop and think, what have we accomplished, but furthermore, what lies ahead? We're gonna keep pushing and pushing hard. And now we have partnerships with pharmacology companies that have developed synthetic blood. We actually participated in trials, clinical trials for testing synthetic blood in people that cannot take, whether for religious purposes or cancer purposes. We've also are working hard to establish close connections with our rehabs such that 5 years ago they would have denied a patient of mine because their blood counts were quote unquote too low. Now they don't think about it, so we keep pushing that envelope. And then our next frontiers will continue to be synthetic blood, of course, for those that cannot take it, but also management of all the coagulation disorders in a proactive fashion so that if you don't lose the blood, you don't really need it in the first place. The future is bright. Our numbers are fantastic. When we compared our program to some programs around the world, their success stories were around 18 and 20%. On a bad month, we're about 36%. So as far as I'm concerned, even though it may not look like much, this program is fantastic and is touching lives every single day. And the experiences are trickling literally across the nation. And that is in part because of the community support. which are not only the people that request it, but support it and drive it. So for that, thank you very much. Absolutely. You're going to hear from an awful lot of people today, actually 4 more, and you'll get to hear a different taste of what PBM is doing in the community. And I hope that when you go home, you get a better sense of what kind of program we have, the things that we can do, but above it all, take pride in the program that is from your community, because some of the things we do around here are not done in other places, and that is something to be very, very proud for. In any rate, they're kind of ticking me, so I guess I should be quiet now. Anyway, stay in touch. We'll keep pushing, and we'll keep sharing some of our success stories as they come around. Thank you very much.
In a patient who is anemic going into surgery, they're already behind the 8 ball because they're going to lose blood with surgery, and therefore their capacity and the capacity of the blood to carry out the necessary functions is lost. Therefore, that patient will need a blood transfusion, or really a blood transplant. And blood transplants that we know of someone else's blood, and older blood, stored blood, is nowhere as good as the patient's own red cells.
Ladies and gentlemen, please welcome Dr. Anthony Torres.
Good evening, and to start off, my portion of the talk is going to deal with patient blood management in the outpatient arena and how our primary care doctors and patients can come to utilize this new technology. I would like to thank Dr. Tibby, Dr. Chapa, and Dale Black for inviting me to participate in this conference. So the first slide here, where patient blood management has been a process and service that we've been utilizing in the hospital, and we found that we've been so successful with it that we will be utilizing it now in the outpatient arena. Questions regarding what is patient blood management? When would my doctor consider referring me for a blood transfusion? And why is patient blood management necessary? So these are kind of really core questions of how we utilize these products. Patient blood management in the outpatient setting refers to the appropriate utilization of blood and blood products based on current scientific data to improve patient outcomes. Patient blood management is a safe and effective use of medical and surgical technology to prevent anemia and decrease bleeding in order to improve patient outcomes. Patient blood management is necessary to conserve a precious commodity and resource that we know as blood. It also is utilized to improve patient safety and minimize hospital-acquired complications as a result of utilization of blood products. Blood transfusion may become necessary when there is a large blood loss that the body cannot accommodate for over an extended period of time. It can also become necessary in the face of increased red blood cell destruction. Diminished or decreased number of red blood cells in the system is called anemia. Worldwide, anemia is noted to be most severe in underdeveloped countries. The most accurate way to measure anemia is by measuring an entity known as hemoglobin. Hemoglobin is carried on the surface of every red blood cell. Anemia affects approximately 4% of males and 8% of females in the United States. Numbers noted on this graph are significantly higher in underdeveloped countries. Utilization of blood and blood products in the outpatient setting is most commonly due to anemia. Anemia is defined by a decrease in the level of hemoglobin in the blood. This hemoglobin can be measured by a simple blood test known as a CBC or a complete blood count. As you can see, normal hemoglobin for men is 13.5 grams per deciliter and 12.5 grams per deciliter for women. There are several categories that cause anemia. One, obviously, is acute blood loss. Secondly, you can have increased destruction of the red blood cell. And lastly, you can have increased destruction of decreased red blood cell production. So those three categories are usually the main categories we look for when we're looking at anemia. Causes for anemia can be acute, such as an acute blood loss from an injury, or more often than not, they're chronic. For the purpose of this discussion, we will be focusing on chronic conditions, which typically are noted in the outpatient setting. Common causes of chronic anemia are due to decreased red blood cell production and include nutritional deficiencies such as iron deficiency, folic acid deficiency, or vitamin B12 deficiency. We also are noted to have anemia when there's chronic malnutrition, in addition to chronic liver disease and chronic kidney disease. Other causes due to increased red blood cell destruction are uncommon disorders such as sickle cell anemia, thalassemia, hemolytic anemias, and other types of autoimmune disorders. Bleeding disorders can also lead to chronic anemia. Bleeding is noted as either a primary hemostatic problem or a secondary hemostatic problem. That means the body's ability to clot when there is an injury. Bleeding disorders are due to ineffective primary or secondary hemostasis. Hemostasis refers to the ability of your body to promote adequate clotting at the site of injury. Secondary hemostasis utilizes multiple plasma clotting factors to create a fibrin strand which strengthens the platelet plug. Whenever there's an injury, the platelets that circulate in your bloodstream will go to that site of injury. They have several proteins on the surface, and those are very sticky, so those platelets will form a kind of a blood clot or a plug at the site of injury. The secondary hemostatic process produces something called fibrin, which strengthens that clot and closes the injury. Coagulation factors are produced in the liver and activated in the bloodstream. Abnormal bleeding can be the result of chronic liver disease, a clotting factor deficiency, or the use of common medications known as warfarin or Coumadin, or vitamin K deficiencies. Normal hemostasis or normal clotting requires a number of events to occur in sequence which promote clotting. They include vasoconstriction, meaning constriction of the artery, the platelet aggregation at the site of injury, formation of blood clot, and then ultimately what we call recanalization, or that clot gets refined and opens up into that artery again. So outpatient patient blood management, what does that mean? This is a new approach, and it's going to really take a team to really evaluate and assess this, and this is going to occur probably prior to anybody really considering any type of surgical intervention. Preoperatively, you're going to require a visit with your primary care physician and or your surgeon. Intraoperatively, the anesthesiologist and the surgeon are going to be managing parameters during surgery to note if there's any problem that could suggest bleeding. And then after surgery, the surgeon and the hospitalist in the hospital will monitor you for any evidence of bleeding. The preoperative setting indicates where the primary care physician is best utilized in outpatient blood management. identification and management of anemia and bleeding disorders in the preoperative stage can significantly optimize the patient's intraoperative and postoperative course. Current evidence shows that the appropriate utilization of blood and blood products has significantly decreased hospital inpatient adverse events. With this being said, adoption of patient blood management concepts are evolving in the outpatient setting. This is best illustrated by a statement from the Society for Advancement of Blood Management. The timely application of evidence-based medical and surgical concepts designed to manage anemia, optimize hemostasis, and minimize blood loss in order to improve the patient outcomes. So that statement encompasses every single phase of this approach: preoperative, intraoperative, and postoperative. Current evidence shows that 1/3 of patients undergoing non-emergent surgical procedures have potentially treatable anemia. Preoperative anemia is associated with a nearly 5-fold increase in the odds of non-cardiac postoperative mortality. An improved diet and replacement of iron, folic acid, vitamin B12 over a 30-day period can markedly improve anemia in the preoperative phase. In addition, appropriate utilization of a hormone called erythropoietin in patients with chronic kidney disease can also improve anemia. Correction of bleeding disorders require more investigation to identify whether there is a platelet dysfunction or a clotting disorder. This should be identified in the preoperative phase. In order to optimize postoperative outcomes for patients with chronic anemia or bleeding disorders, there is a continuum of care that should be followed. This illustration shows that to optimize postoperative outcomes, you must begin with a thorough evaluation in the preoperative stage. An appointment with your primary care physician and/or surgeon, which should include a medication history to assess if any medications can affect bleeding. Secondly, evaluation for any personal or family history of bleeding disorders. Identify any chronic disease process which can increase the risk for bleeding. Thirdly, perform a physical exam looking for signs of bleeding or evidence of jaundice or spleen enlargement, which can increase the risk of bleeding. This illustration shows you what the operational improvements can be with pre-surgical assessment of anemia. This should take place at the minimum 30 days prior to any elective surgical procedures. What laboratory test for a preoperative anemia evaluation? The first tier test would include the CBC, a test called a reticulocyte count, vitamin B12, folic acid, and iron studies, and a measurement of your serum creatinine to check your kidney function. If these tests are abnormal, then you would proceed to the second tier, which includes TSH, or a thyroid test, something called a C-reactive protein, methylmalonic acid, a protein electrophoresis, erythropoietin level, and something called a haptoglobin. The second assessment would be for bleeding. Preoperative bleeding risk assessment is as follows. This is a very busy slide, and I'm going to make it really simple to understand. Again, you're going to obtain a thorough medication history for any and all medications or supplements that can affect bleeding. Anything that will affect the platelet or clotting factors. things such as aspirin, warfarin, clopidogrel, something that a lot of folks know, ginkgo biloba, ginseng, garlic, and dong quai. A lot of these substances are contained in a lot of supplements that people are taking on a regular basis for multiple different reasons, and they don't even realize it. And these are things that are really important that can affect your bleeding tendencies in a surgical procedure. Secondly, look for a personal or family history for abnormal bleeding. The physical examination to identify any unexplainable signs that would suggest bleeding. And the most important part in this last sentence is really, if all the initial screening tests are negative, there's no further testing that's required. This concludes my presentation for preoperative, intraoperative, and postoperative assessment. In my estimation, I think that taking this patient blood management program and moving it from within the hospital and taking it to the outpatient arena is going to really, really improve outcomes for our patients and identify issues that can be easily corrected to maximize their outcomes and minimize their complications. Thank you.
Since blood is a foreign product, people react to it. It's actually immunosuppressive. It can have some effects above and beyond just giving those red blood cells. And there are many studies that show you actually, the more blood you transfuse, you may actually be hurting people rather than helping them. So we're trying to limit that. We're trying to be very smart about how we do it.
Ladies and gentlemen, please welcome Dr. Richard Bassett.
Good evening. I'm Rich Bassett. I am an orthopedic surgeon here in Prescott Valley, and mostly specialize in hip and knee replacements. I was originally, one of my partners was supposed to be here and giving this lecture, but he ended up having an injury and breaking his ankle. I told him there are easier ways to get out of a presentation than break your ankle, but hopefully he has a speedy recovery. I feel very strongly about blood management. Again, I'm a hip and knee surgeon, so my goal is to give the best outcome to my patients. Some good words by Albert Einstein here, and we're going to kind of talk about hip and knee replacements and how managing preoperatively, operatively, and after surgery can have a big impact on recovery and also outcomes. You know, certainly preoperatively, we always are going to check somebody's blood levels before they have surgery and see kind of a starting point. Obviously, the higher they are, the better. And so if they are low, we are going to do things to try and correct that prior. A hemoglobin of around 13 has a higher possibility of blood transfusions during surgery. When it gets under 13, especially on hip surgery, we do a special approach, anterior approach hip replacement that has a slightly, higher blood loss than maybe a knee replacement. We want to make sure those blood levels are high enough to start. And so we want to optimize those. One way we can do that is we can give iron and different things to try, and if they're just a little bit low, you can raise them up with iron and other things. Sometimes IV iron is also necessary. Under 11, if their hemoglobin's there's other medications, erythropoietin that can be given as a weekly treatment a few weeks before surgery. And so we obviously work with our family practitioner doctors to try and manage these, and if things are not improving, hematologists are also sometimes involved in trying to figure out the diagnosis and why their blood levels are low to start with. Once we have got them up to the adequate levels, then we certainly can have a better outcome for our patients. The type of surgery, intraoperatively, there's a lot of things that we can do to try and manage blood. there's a term out there that they say, you know, a slow surgeon is never a good surgeon. You want to be quick, and one reason is because the quicker you are, to a certain extent, the less blood you're going to have. You want to be a good surgeon as well, but you don't want to just be quick. You want to be quick and good, because the longer you're in the operative room, the more chance there is of bleeding. So you want to be efficient, I guess, is the key. There are some newer medications, something called tranexamic acid that has been around for a little while, but nowadays is pretty much standard. For most hip and knee surgeons, I go to national meetings, and pretty much everybody, when they do a hip and knee replacement, they're using either TXA, which is tranexamic acid, another one is Amicar, and these can be given IV. I typically give a dose of IV TXA just prior to incision and just prior to close. You can also put this medication into the wound. So at the end of your surgery, you can put it in there, and it has a clotting type factor around there to help decrease blood loss. And since these have been employed, there's a very rare need for transfusions with a primary total hip or total knee replacement. I can't even think the last time on a primary that I've had to do that, just because of these medications are so good. And so that's been a big change in the orthopedic over the last 10 years or so. Multiple studies talk about, you know, the effects of these. And so, of course, our goal, we want at every step, preoperatively, where they're at, intraoperatively, what we can do, and also postoperatively, what we can do. And so we want to be very careful in our, you know, cauterizing the bleeders as needed as you're going through the surgery. So the perioperative management of blood affected multiple things: physical function, morbidity, length of hospital stay, and mortality. The first one, physical function. When I do a hip or knee replacement, my goal is to get the patient up and walking within a few hours of surgery if possible. And if we can do that, we can get them up and back to life a lot quicker. If there was, you know, loss of blood or something like that and had anemia, maybe we can't do that. That delays the patient getting up and getting around. And so, you know, it certainly can affect function. Every day that the patient is anemic can shorten the time that they can walk with physical therapy, and it delays things, and there's longer hospital stays and all sorts of things. So we want to try and minimize that. Morbidity. Some studies have shown that anemic patients have a higher rate of infection, and that's the last thing you want. Do everything possible to avoid infection in hip and knee replacements. And so, you know, that's just another key part of treatment of patients, is to try and maximize their outcomes. And so blood transfusions also have a higher rate of infections. So the last thing I want to do is give blood if I can in any way avoid that. Length of hospital stay. When you give blood and they're anemic, that always lengthens the stay in the hospital, and, you know, puts patients at risk for other, you know, complications. And so the quicker you can get a patient in and out of the hospital, the better, safely. Mortality. There is a association with increased mortality with anemia, and a lot of the studies deal more with hip fractures, but patients, there is some evidence that patients with anemia less than 10 were 5 times more likely to die in the first 6 to 12 months after that than those who were mildly anemic, between 10 and 12.9. Economics as well. You know, obviously there's a cost for the blood, and there's sometimes shortages, and so, you know, increased length of stay and admission can cost, you know, billions across the healthcare spectrum. And so certainly there's a lot of literature that points to increased mortality and morbidity when you need to do transfusions. So in conclusion, patient's blood management is, you know, at the forefront of what we do in orthopedics, in any kind of surgery, not just hip and knee replacements. It's something that we're always thinking of, and something we're always trying to manage and find ways to minimize it. But again, that starts in all phases, preoperatively, where they are. And some patients, you know, they have a bad knee and they want it fixed right now, and I understand that, but at the same time, my goal is to minimize the risk as much as possible. And if I can do that, then hopefully we can give them the best outcome possible. Intraoperatively, we talked about those things that we can do with the newer medicines, TXA and Amicar, and then obviously, decreasing the length of the surgery and making things more efficient can help the patient. And then postoperatively, getting them up and walking and all those type of things can decrease complications and problems. Thank you.
I've always known there was a better way to protect our patients and deliver the best care possible. I just didn't realize it had a name till now, and that's patient blood management. I remember 20 years ago when we talked about this amongst the nursing staff, the idea about maybe we give too many blood transfusions or could there be an alternative. I was introduced by colleagues that there are certain groups out there that do not desire blood transfusions. And for some, it's devastating if they receive one. These conversations amongst the units led us to discuss various ways we could conserve blood or approach different therapies. That was 20 years ago. We didn't have a name for it then, but we do now, and it's patient blood management.
Ladies and gentlemen, please welcome the Director of Ethics at YRMC, Jill Logan.
Good evening. It's great to be here. Thank you to Dr. Dale and Dr. Tibby for the invite tonight. I'm going to move things a little bit away from the clinical side and talk about the role of ethics in patient blood management and the right thing to do. So for those of you that don't know, in about 1990, the Patients' Rights to Self-Determination Act was passed, and that's where ethics committees came from. So at that time, the Joint Commission of Healthcare looked at hospitals and said we really need to change from this paternalistic approach to healthcare to patient-centered care. And advanced directives came out of that during that time, as well as ethics committees. So every hospital in the United States has access to an ethics committee. At YRMC, this is our goals. I also do ethics consultation at the Prescott VA. But I'm going to talk a little bit about YRMC and what the ethics committee does and what our goals are. So to promote the rights of patients, to promote shared decision-making between patients or their surrogate decision makers if they can't make their own decisions, and their clinicians, to promote fair policies and procedures that maximize the likelihood of achieving good patient-centered outcomes, and to enhance the ethical environment for all healthcare professionals. So what does that mean to you all? Anyone can ask for an ethics consult. It is a confidential service. YRMC's ethics committee is available 24/7 to assist with those consults. It is a multidisciplinary committee. There's community members, board members that sit on our committee, multiple physicians, nurses, and bedside staff. Once again, anyone can ask for that consult, and it can be confidential. If it's not confidential, there is a note that goes into the medical record, and there's families and patients are invited to tell their stories so that we know that the decisions that we're making are patient-centered. And anywhere that YRMC owns or goes has access to this service. So what is an ethical issue? It can be something that we see at the beginning of life, conflict about treatment decisions for newborns, maybe conflicts between adoptive parents versus biological parents. It can be all the way to the end of life. And really it's a conflict in values. If there's some concern or disagreement amongst a decision or the values that drive healthcare decisions, that can be at the base of what an ethics issue is. On the screen there, you'll see some lists. That's just a very small example of ethics issues that we can see in healthcare. And then we have ethics principles that guide these decisions and mostly guide the conversation. So you'll see those topics like patient autonomy. What is the patient's perspective of their healthcare concern, and what's important to them at this time, and how do we go about making sure that they have the right information to make a decision that affects themselves and their treatment decisions. And then as a healthcare professional, we have an obligation to tell the truth about what this person's options are in their care, make sure they're informed, like informed consent or informed choice, and that the decisions that we offer to that person promotes good and does not harm them. And then we look at being fair from an individual point of view all the way to a community and statewide, that those things that we offer as far as community-based resources, family support, that's fair and equitable across the continuum. So in patient blood management, I was thinking about this topic and how ethics affects these decisions in patient blood management. It's really to have open discussion with our patients about their needs, desires, and concerns, that we are open in our treatment possibilities, that we're listening to that individual to make sure that if they have a specific request or specific denial, because adults do have the right to formulate their own decisions regarding health care, and we want to make sure that we're giving our patients and those adult patients as much information as we can, and then listening to their answers so that the decisions that that person is making at that time make sense to them and that there's no surprises in their treatment down the road. So we talk about informing the risks, the benefits, and alternatives of treatment choices. And then we partner with the patient to decide on a course of action that respects their wishes and their rights to their own health care decisions and their autonomy for making those. And then above all, we want to make sure that we document that conversation in the medical record so that the next healthcare provider who comes in afterwards, we work shift work in hospitals especially, so it's a 24/7 service. And so that conversation doesn't need to be repeated over and over again. It should be documented in the medical record. So any person coming into your care after that should know what's important to you at that time. So this is more about the patient's rights to self-determination. So competent patients have the right to accept or refuse treatment. And then surrogate decision makers serve for patients that lack the ability to their own healthcare decisions. So we're going to talk a little bit more about what is a surrogate decision maker and how do we determine when a person has what we refer to as the capacity to make their own decisions, and then when we move away from that patient to their family members or whoever they may have appointed as their healthcare decision maker. And then the last is patients have a right to make an advanced healthcare directive, which I'm a huge proponent, advocate of, an individual's creating a healthcare directive. How many of you in the room, if I can just have you raise a hand, tell me if you've created an advanced directive or a healthcare power of attorney? That's fabulous to see that number of people. Historically, the number stays at about 25% of us have actually done these documents. So 75% of the time we're dealing with family decision makers when the patient can't make their own decisions. So who are those people? First, let me step back and talk a little bit about how do we know a person can't make their own decisions and what questions do we ask of them? Because it's really important always to hear the voice of our patient and partner with them for their healthcare decisions. And so at what point do we move away? What I like to do when I'm working with someone is to ask questions such as, why are you in the hospital? What's been proposed that you have done? What do you expect the outcome of that decision will be? And if you refuse treatment, what do you think the outcome of that would be? And then I like to take it a little bit further because a lot of the clientele that I'm working with is making decisions that may lead to things such as long-term care placement or long-term ventilator care, or tracheostomy, or feeding tubes, those type of things. And so it's not just about what does that mean and how do we do that surgical intervention, but really how does that affect your life and what can you expect for your future based on that decision. It may even be the financial consequences of that decision, or maybe it means that your future care is going to happen in Phoenix or someplace else. So I want to make sure that when we're talking about risks and benefits and to the patient who has capacity for their own decisions, do they understand the now and then also the future of that decision? So if I'm having that conversation with someone and I see that they're confused, maybe they don't know why they're in the hospital, or that they understand who their family is, maybe it's a dementia diagnosis or something like that, so they can make decisions and recognize their family, but something like a surgical consent or even transfusion or treatment of anemia is foreign to them and they can't understand that. So we go through a whole lot of questions before we move to a family member. So in my conversation with them, I'll say, okay, clearly they don't understand, and we need to find out if they've appointed a healthcare power of attorney to make these decisions. And this is the list of people that we're looking at here. So the first thing that in the hospital setting that we're wanting to know is if the patient who can't make their own decision has a court-appointed guardian. That's something we don't see very often, but the courts have appointed guardian. We'll look at that paperwork to see what that appointment is, and if it includes healthcare decisions, we're going to partner with that person to make decisions on behalf of our patient. For most of you in the room, though, you've probably appointed a medical power of attorney or a healthcare power of attorney, and that would be your go-to person to make healthcare decisions for you. So we're going to look at that paperwork. Because in the state of Arizona, any appointment of a medical power of attorney, as far as the format of it, is okay. What we're concerned about is the witnessing. And in Arizona, it's one neutral witness. It doesn't require that it's notarized, but we do have to have a neutral witness. So I'm going to look at that document. It could be handwritten, or it can be in a more formal paper. Some people have it done by their attorney or estate planner, but it's really up to the individual. And it can also say many different things, so we have to read them. So for those of you that have done that appointment, make sure that that paper is readily available to see. Because sometimes we'll see and the agent the medical power of attorney that the person has appointed can make any decision on your behalf, and then sometimes it's limited by the patient's wishes. So sometimes I've seen where they've said things such as, I authorize my agent to make all healthcare decisions on my behalf, including withdrawing treatment versus adding treatment. And then maybe they'll say something like, I only designate my agent to make decisions to institute treatment but never withdrawal. So it's really important that you know where your directive is and that it can be shown to your healthcare team. The next on this list is an Arizona statute about mental health care power of attorney. So it's another important appointment in our state, so that if the person can't make their own decisions and there's a mental health decisions that need to be made, especially as it relates to admission into a behavioral health unit that's considered a level 1 or a locked unit, our state really request and recommend that you have a mental health care power of attorney that can do that for you. But once again, 75% of the time, our patient population has not done this appointment, and so we go to what's called a surrogate, which are a list of family members who act as the medical decision maker for our patients. So this list here that you see on your screen is based on Arizona statute. And so if you are from another state or getting your health care in a different state other than Arizona, it may look a little differently to you. But in the state of Arizona, if you haven't appointed an agent, a medical power of attorney, to make decisions on your behalf, and you can't make your own, or you don't have a court-appointed guardian, the first person we're going to look to is, are you married? And so the patient's spouse, unless they're legally separated, is our go-to for first-line decisions. If there's no spouse, then it's the adult child of the patient. So in Arizona, that's a majority decision. And so if you have 7 children like my in-laws do and you haven't done this appointment, we have an obligation to seek out all 7 children that are reasonably available to come up with a decision on your behalf. If there's 2 children, they need to agree and so on. Next would be the parent of a patient. So if there's no spouse, no adult child, we're looking to see if there's a living parent next that can navigate those healthcare decisions for you. And what's interesting in our state versus other states is next on that list is if the patient's unmarried, domestic partner is next. And our statute doesn't define that as far as length of time, so it could be a very new relationship or it could be a long-term relationship. And so it really comes down to their living arrangement, that no one else has assumed financial responsibility for our patient, and there's no hierarchy of someone above on that list. Most of the time what I'm seeing is it's a long-term relationship, and they have adult children that they may be estranged from, but we're obligated to follow this order by state law. And so when you look at that list of people, know that there is a reason behind our madness at the hospital, that we are following the law to make sure that we're talking to the right people on your behalf. So if there's not a domestic partner, next on that list is brother or sister, and then after that is close friend. So under close friend, it's somebody who really knows what your wishes are and can act and speak on your behalf regarding your healthcare wishes. So not necessarily someone who just shows concern for your welfare, but somebody who really knows what you would want if you could speak to us regarding your healthcare. And then last is if there's nobody on that list in this person's family. I did just have a case like this yesterday. Then what happens, and who can make decisions for our patients that can't make their own? And what our state statute says is if the healthcare provider, your physician, cannot locate any of the people on the list above, the attending physician may make healthcare treatment decisions after consultation with the ethics committee. So that's another big part. So that being said, you can see I'd be a real advocate for advance directives in my role, because our real goal is, and everything we do in healthcare, is to hear the voice of our patient and to make decisions that are consistent with what you would want us to do if you could tell us. So the role of healthcare professionals in ethical decision making is to be knowledgeable about patient blood management and the indications for the treatment of anemia, to inform patients about the risks, benefits, and treatment alternatives in the management of anemia, and be committed to practicing with honesty, integrity, accountability, and always respecting the patient's right to accept or refuse treatment. So the pretty picture in my conclusion is to just know that the ethics committee in hospitals is there to assist you and to make sure that your voice is always heard in the decisions that we make in your care, and to honor you and what it is that you request moving forward in your hospital care. Thank you.
When I came to the realization that patients who do not receive blood transfusions generally fare better than patients who do get them, I realized that was an important thing to know and learn and promote. That's why I helped take the lead here at Yavapai, promoting patient blood management.
Ladies and gentlemen, please welcome back Mr. Dale Black.
So in the past 5 years at Yavapai Regional Medical Center, we've had numerous patients travel all the way up to Prescott or all the way down to Prescott, all the way over from the Colorado River here or from Mesa to receive care here. Now, why would people travel all that distance up to this hospital, this little regional hospital in Prescott, Arizona? Well, please welcome Brian and Phyllis Multari, and they'll tell us our story. So Brian and Phyllis, we want to thank you very much for coming up here all the way from Mesa to tell us a bit of your story about your experience here at Yavapai. We appreciate that. But if you would, tell us a little bit about yourselves, your families, where you come from, and all that good stuff.
Okay, Dale. But first, would like to thank you, the Yavapai Regional Medical Center, the Dr. Tibby, the staff at the center, and the Patient Blood Management Program for allowing us to be a part of this seminar. We sincerely hope that telling our story will encourage others to be very proactive in your health care.
It's our privilege.
First of all, my name is Brian, and my wife Phyllis and I have been married for 37 years.
And those have been 37 fabulous years.
Excellent.
So we have a daughter who's been married for 15 years to her best friend.
And we have a son, Ian, who's going to be getting married on Saturday.
You mean 2 days from
Yes.
now? Cool.
So our small 2-child family is now 4, or will be 4.
Excellent.
So we're a little melancholy this week because we've watched him move out.
Well,
But it happens.
absolutely. So then, why don't you share with us your story? What brought you up here in the first place? And I'm just going to let you wing it. So just go with what you experienced. We'd like to hear it.
Okay. Well, it was kind of an ordeal our coming up to Prescott. The first cardiologist I had was pretty insensitive, and he really wasn't up to date on current procedures. He told me, my wife and I, that if I was unwilling to take a blood transfusion, that I might as well go home and die because I wouldn't be able to find a surgeon that would do the surgery, without having that as a backup. Well, needless to say, we did go home, but not to die. I went home, we did a little research, and we found another cardiologist that was a little bit more up to date on surgical practices and patient preferences.
So the second cardiologist that we saw was very willing to work with us. He suggested surgeons that could be capable of doing the surgery. But all of them wanted Brian's hemoglobin to be at 14. None of them were proactive in getting him there. It was at this time that we had a friend who really encouraged us to come up to YRMC and see Dr. Tibby. And these were 2 names that kept coming up during Brian's ordeal. We also learned that Consumer Reports in 2013 had rated YRMC as one of the top 10 hospitals in the nation for best care practices and also low infection rates. So that really prompted us.
So here it was, August of 2013, and we're going to Prescott. It had been a long process. We'll give you a little bit of background. In 2012, I came down with sepsis, a pretty bad case.
It was not a pretty bad case. It was an awful case. So we had absolutely no idea where he got the sepsis from, but at that time, Brian's kidney function dropped down to 7%. He was put on dialysis almost immediately. His hemoglobin went to 3.8, and his platelets plummeted. So after spending about 6 weeks at an East Valley hospital, we arrived at the Mayo Clinic. Here we had a whole team of doctors who were willing to come together and put a plan of attack together. We had a hand surgeon who operated on Brian's hand 3 times to try to remove the infection. And over the course of 2.5, 3 months, we did see some small improvements. He was eventually able to come off dialysis, but we had another little problem. Because of the sepsis, he now had endocarditis, and so we knew that he was going to need heart surgery eventually. So we had 8 very stressful months, 4 in the hospital, and then 4 at home when his kidneys finally started to improve, and he was off dialysis.
So once I was out of the hospital, learned to walk again, and then after coming off of dialysis, my strength started to rebound. So at this point, we knew that it was time to start looking for a heart surgeon.
We thought so anyways. So we ended up coming up here, and we met with Dr. Tibby, and he was immediately very proactive. He considered Brian a fascinatingly complicated challenge, and he was very willing to accept that challenge. It was amazing because in just a few weeks, Brian's hemoglobin went from 10 to nearly 18. We were ready.
So from the very first time that we met Dr. Tibby, we were at ease. I knew that he was the surgeon that I wanted to do the surgery. So because of his being proactive, my hemoglobin was up, and we made the trip to Prescott for the surgery. Anybody that has been admitted to a hospital knows that almost immediately they draw blood because they want to find out how you're doing on the inside. And they did. And a little while later, Dr. Tibby strolls into my room, sits down on the end of my bed, looks at me and tells me, "We have a little fly in the ointment."
So unbeknownst to us at the time, Brian had actually developed ITP, and his platelets had dropped in the time it took us to drive from the East Valley all the way up to Prescott.
At this point, Dr. Tibby told me, or told us, that he had never lost a patient on the table and that I wasn't going to be his first one. And I was glad of that. But once again, he was very proactive. There was an immunoglobulin called Winro that has been known to raise platelets in 24 to 48 hours. Now, the surgery was to have taken place on Friday. So he said, "Let's keep you over the weekend. We'll give you this, and we'll see where you're at on Monday." It didn't work, unfortunately, and so I was discharged. And it's about, like I said, it's about a 2.5-hour drive back to where we live. So we decided we were going to have lunch here in Prescott before we left. So here we are, sitting in this little Italian restaurant, and
We were so busted. We were busted.
one of the nurses from the cardiac unit was like 2 tables over from me. But that's not the surprising part. The surprising part is that she knew my name. The entire staff in the cardiology unit, when you came in, they took the time to get to know you. They showed you respect. It was very impressive. I was amazed. So yeah, we were busted, but then we went back to the valley.
Okay, so we go home, we come back. Tibby wanted to make sure that Brian was really ready for surgery. So we come back.
Yes, it's been about 2 weeks. He had put us on an alternate plan. And so we come up to have the surgery. It's all good. We get in, my platelets are okay, kind of bordering, but yeah, we're going to go ahead. And they take me back to the prep room, and I wake up a couple of hours later, and I've got all these tubes in me, and I don't feel any pain. I don't have any scar. I knew that Dr. Tibby was a good surgeon. But come on. Well, the surgery did not take place. There was a reason.
So we had a new obstacle, and we discovered in this time period that because Brian had been at the Mayo Clinic and the other East Valley Hospital for so long and had tubes in him from the sepsis, that his external jugular veins had actually collapsed. So they couldn't put the arterial lines in. So while he's asleep, he goes off to vein mapping, only to wake up later a bit disappointed, more than a bit disappointed. So, I told you he was fascinatingly complicated, and so the story continues.
Once again, it was a Friday. So it's okay, well, he's all prepped. He's got all the tubes. Let's just wait till Monday. We'll reschedule it because it was too late in the day. And Monday came along, you know, they do that blood work thing, and again.
Okay, so here we go again. His platelets drop again. So it was at this time Tibby consulted some of his other colleagues, I believe in Texas, I want to say at this time, to get a team effort going so we can have another plan of attack.
Once again, that proactivity really came into play. We were sent home with a regiment called N-plate. And this is an immunoglobulin that's taken over a series of weeks. Well, in about 3 weeks, my platelets were around 375. Very safe. It's time.
This is like the highest I've been ever. Okay, so we drop everything, no matter what we're doing. We drop it. We head up to the up to Yavapai, and all I can say is I was just really grateful at the time I had a super great boss, because this is like the third trip up here for a week. So.
Okay, so I'm ready. I'm in. They take me back. For some reason, I'm awake in the operating room. And I see all the nurses and the doctors and an anesthesiologist, and they're all moving around. And they're playing music. It's kind of cold, but they're playing the Bee Gees song, I Feel Like Dancing. And the next thing I know, I'm waking up in the recovery room, and Phyllis is with me. And she asks me how I'm feeling. Well, the last thing I heard was the first thing I said. I feel like dancing.
Now, mind you, I'm recording this too, so I have this for all posterity for us. So, but yeah, that was it. We had success. Yay!
Thank you for sharing that great story. So now, Phyllis, any closing thoughts that you might have for this audience?
I would say stick with it. We had one obstacle right after another, and there came points of time when all I could do was just break down and cry. And good thing I had good friends around me, because they were the ones that picked me up and pulled me up and said, "You're going to make it. You're going to make it through this, both of you." You know, we moved here in 2000, and we don't have any immediate physical family around us other than our children. But the friends have been awesome in helping us and supporting us. My advice is be your spouse's advocate. Be an informed consumer. Expect reasonable and satisfactory answers, not only from your doctors, but also from the medical staff. And have hope and know that there are other healthcare options. We have absolutely no regrets in coming to Yavapai. We are extremely happy with the tender and personalized care that we received. And I feel very honored today to have Brian with me so that he can see his son get married on Saturday.
Brian, do you have any advice for this group?
Dale, our experience at Yavapai Regional Medical Center was exceptional. We were treated with dignity and respect by the entire team. Although it took 3 trips to Prescott to finally get the surgery done, I was never anxious.
I was.
I knew that when I was ready, when everything was ready, that I would have the surgery. I felt no danger. That being said, anytime I have an opportunity to advise somebody needing a medical procedure, I always mention the Yavapai Regional Medical Center. To coin a phrase from the TV show MASH, it was the best care anywhere.
Thank you. Thank you.
Yeah, it was our pleasure.
I had an aha moment when it came to patient blood management approximately 20 years ago. I dealt with a lot of patients who refused blood across the board. After I had done about 50 to 100 patients, I realized that my patients who didn't get blood were doing better than the ones that did get blood. And therefore my moment was, gee, let's do this on everyone.
We are now pleased to announce and to welcome as our panel discussion moderator, Dr. Pierre Tibby.
Good evening. Yeah, good evening. Really happy to see you here again. They're not letting me talk this time because I'm kind of getting old. So they just gave me a little perfunctory task of asking questions, which I think I can handle. But first I want to say that with patients like that really makes for a wonderful experience everywhere. He was so understanding. The family was so supportive. They knew that we wanted their best care, that we wanted the best for them. And it was a real team effort. So first I want to thank the presenters here. I think you saw an excellent job done by everyone. And now we're going to ask some questions. These are questions that have been submitted either through the internet or online in post-event surveys from the last talks that we've had. But before I do that, I want to say something. So when I was a kid, my parents told me not to get into strangers' cars. And when my kids were growing up and they were fooling around online on the internet, I told them, don't talk to strangers, and by all means, don't give them any personal information. And now, we literally summon strangers over the internet, tell them where we are to take us to other places, like Uber. It doesn't make sense, but times have changed. And that's exactly what's happened. As Dr. Chapa said, many of us, and not too long ago, we were teaching in schools in medical schools, that blood saves lives, that blood can only be good, that if somebody is feeling a little weak or pale, give them a unit of blood just like you put a quart of oil in a car. And we have an overwhelming amount of evidence now that blood actually has risks as well. Everything has risks and benefits, and whenever blood can save lives in the appropriate situation, but we have to, like everything else that we do as physicians and nurses, everything that we do, we have to assess the risks and the benefits and weigh them out and know which way to go. We don't want this. You know, we've heard some great things about YRMC, and this is not a commercial for YRMC. This is a way for us to continue to give to the community because the community gives back to us and educate about certain things, and specifically, obviously, blood management, because we've done a fair amount of work here in blood management. So, I will go ahead and ask some questions to our panelists. So let's see this first one. Why is the Advanced Healthcare Directive important? But obviously you don't have to tell this audience because most of them have it.
This is the best response I've ever had in a presentation for completing an advanced directive. So this group obviously knows the importance of them, but what you can do with that is take it out and tell others, because as I touched on a little bit in my talk, that sometimes without these directives, especially the living well, the living well is where you say the healthcare treatment decisions you would want in the event you can't tell us yourself. That is hearing your voice through not just your voice, but your values and what's important to you, especially as you face end-of-life decisions. And without that, family members are very stressed trying to come up with these decisions and trying to, it's more of a burden to your family to say, what do you think we should do versus aren't we so lucky that your father told us what he wanted in this advance directive and we're going to give him the dignity that he asked for at that time. And so it's a beautiful way to support your family, to not put that added burden on them to make these decisions, but to also get the care that's important to you even when you can't communicate.
Thank you. Another question that was asked was, and I'll direct this to Dr. Bassett, what are some key steps I should take if I have an elective surgery coming up and do not wish to receive transfusion of blood products?
Well, I think the biggest step is kind of finding out where you're at, and then once you have that baseline, to work with your family practitioner and even a hematologist to take iron or IV supplements or anything you can do to try to increase that, because that's can't really do surgery without any blood loss. You can certainly minimize it, but there's going to be some. So the higher you can get it preoperatively, certainly the better you're going to do. And there's plenty of treatments to help with that.
This is a conspiracy. All right. Another thing, and he's not going to say it because he's kind of humble, but his group is fantastic. They've been a great partner for the PBM program from the get-go, because they will not hesitate to delay a surgery until your blood counts are appropriate. And I will get texts every so often on my week off. Hey, I have this guy. What can I do? What would you? And we still help each other. For those of you who will be displeased with the answer, know that it's the best thing for you to delay that surgery until it's safer. For those of you that decide to shop around, you will find somebody who will do the surgery, but your outcomes will certainly be worse. So if that is not a sign of integrity and professionalism, I don't know what it is. Now, he can't say it because then he wouldn't be humble, but being the chair of the committee, I deal with these issues and I see it every day. So choose your surgeon wisely.
Thank you. Rich, one of the questions was...
I paid him earlier, it's okay.
One of the questions was something I recently heard about, platelet-rich plasma therapy. What are the doctor opinions regarding this? Do you use that at all in your surgeries?
So I don't, but there certainly is some literature out there. It's becoming more and more prevalent, just like stem cells and other things. I mean, I think a lot of things haven't really, completely been proven to help, but it certainly is an option to do that. And, a lot of surgeons use it to treat tendinitises and injections and things like that. They also, after a rotator cuff repair, they might inject it. And I think it's certainly an interesting concept, but I don't know if it's been, completely proven
So
yet.
what platelet-rich plasma, it's actually you take the red cells out of the blood and by putting it in a centrifuge, and that spins the red cells off, and then you've got like a yellow serum, and you split that off into platelet-rich and platelet-poor. There are two factors to that, and each of them have different properties, but both of them can be hemostatic, meaning they can help with clotting, and it's also vasoconstrictive, which means it constricts the blood vessels. That obviously, constricting blood vessels can obviously help with any kind of oozing. We use it in heart surgery as well as in orthopedic surgery. Now, but the problem is that it's getting a lot of attention in many other things. Has anybody ever heard of vampire facials? Okay, it's horrible. I see a picture on it on the internet, and basically they're taking this platelet-rich and platelet-poor plasma and injecting it into women's faces, and it's supposed to make them look younger or something like that. But there's been a lot of uses for it, but there certainly are some good uses for it in orthopedic and cardiac surgery, as far as I know. I don't know about the vampire facials. Doesn't look good, though. Doesn't look very nice at all. Dr. Torres, one question was, why should I speak to my PCP about anemia treatment?
So the subject matter, like I described it in the preoperative phase from your primary care physician, which could be your family practitioner or an internist, the statistic that really stands out is really that 1/3 of patients going to surgery have an easily correctable anemia. More often than not, it's a nutritional deficiency. It's iron, it's B12, it's folic acid, whatever the case may be. But you have a 5-fold increase of having a post-surgical complication by not correcting it. So this is one of the factors that I think is really going to play into the preoperative evaluation with your primary care. If you're going for an elective procedure, if you have anemia, a minimum of 30 days to delay the surgery to correct that will significantly reduce the complication risk of your surgery. So in my estimation, that's a really small, it's very easy to correct it with supplemental iron. You can take that orally, B12, folic acid, very simple to take and very easy to increase the numbers. So that's the question your primary care physician should evaluate and assess before you even think about having surgery.
Thank you. Larry Burns. If I want or need a blood transfusion at Yavapai, will blood be available at the hospital, or are we just going to go completely take it off the shelf?
They told me there would be no questions for administrators.
Oh, there are plenty of questions for administrators.
But yeah, so I think you heard many times tonight the preparation of the patients for addressing their anemia pre-surgery and things like that. And you probably heard the word unnecessary transfusion many times throughout the clinical presentations and things. But if blood is, and we also acknowledge that blood is needed in certain situations in the right area. And when you need blood, they'll be available at the hospital. The blood bank resides as a portion of the clinical laboratory, a part of the division in the hospital. And we have full service blood bank, and it's accredited both by the American College of Pathology and also the American Association of Blood Banks. So when you need blood, it'll be properly typed and cross-matched, and blood will be available when you need it.
Thank you. Dale, does the panel think, well, I guess the panel, does the panel think that...
Can I say something?
No.
I knew this would be
embarrassing. All right, go ahead.
Oh, thank you. I want to talk about communication and conversations. It both goes to Jill's comment about advanced healthcare directives and durable powers of attorney. Those are pieces of paper that are vital. We got to fill them out. But those are embodiments of conversations between family members or loved ones that have already happened. So the conversations that lead to the documents are as important, because then if you have a relative or a next of kin or a durable power of attorney who's never talked to you about what's on the paper, they're still going to be in a world of hurt to try to figure out what you really want. So conversation, communication. And to Dr. Torres's point about your PCP, you need to have a conversation with him about your blood condition. You need to let him know you are deeply interested in knowing if you need to address any anemic situation. So that proactivity that Phyllis Moltari talked about, being proactive, it's an obligation we have for ourselves and for our families.
Thank you. Very excellent point. So does the panel think that patient blood management will eventually become the norm in all hospitals? Well, I can answer that very easily. Patient blood management is now being looked at by all specialties, by all hospitals, by regulatory agencies. Use of blood is one of the most overused therapies in the United States. Not only that, it's worldwide, and it may be for different reasons. For example, in China, with its upside-down, until recent one-child policy, there are a lot of older people that need bloods and very few people who can give blood. So their blood is at a significant shortage. Through many parts of the world, in South America, Africa, Southeast Asia, hemovigilance, meaning looking for giving safe blood or the availability of safe blood is almost non-existent. So for numerous reasons throughout the world, patient blood management is extremely important. And, you know, I think that this hospital, this administration, the physicians, the nurses that work at this hospital have really made it a guiding light. We probably have some of the lowest, if not the lowest, transfusion rates, at least in cardiac surgery, in the world. No kidding, in the world. We just presented a paper of our transfusion rates here from Yavapai at an international meeting, and it's almost embarrassing because they don't believe you. But it is in fact true. We have it checked with statisticians from ASU. So that's how significant it is. And it's not one person. It's not a group of people. It's the entire community. It is the physicians, it is the nurses, it is the people in the blood bank, it is the administrators supporting this, and it's the patients understanding why blood may not be given, or other treatments may be given, or a procedure may be delayed, so that we can give you the best possible outcome. So I think the answer to that is it is becoming the norm. It should be the norm everywhere, and it is becoming the norm everywhere. Anybody else want to add to that?
You know, I've always had a soft spot for underdogs. I don't know why, you know. When I was watching Star Wars, I was rooting for Darth Vader, you know. And then this guy, Luke, keeps coming back and messing the whole plot. But all kidding aside, when you look at the management of a lot of serious conditions in the ICU, you will always see the first tenet of that to be supportive care. And when you can take blood, that's fine and dandy. When you can't, because you've had so many transfusions from cancer or the blood disorders or personal choice, traditionally it meant that was the end of the road. And I've always been personally bothered by that. Not that I have a problem letting go. It's the problem that the science, I felt, stayed behind the curveball in this particular issue. Once you transition from sort of the standard of care to being more PBM conscientious, you realize that there's so many other options and that the outcomes are so much better than all of a sudden you're wondering, why haven't I done this for everybody else? And now, I'll tell you, last time we reviewed the numbers in the committee, 90% of anybody that came with a massive hemorrhage was treated in a PBM setting. The vast majority had no issues with taking blood. They would have done it if said so. And yet, the way that we've changed our practices has made it such that the biggest benefit now is for everybody, not just for the select few, so to say. So that also goes, you know, a little bit to kind of dismiss a myth that the reason we're here is because we're trying to cater to a certain population. The reality is that this came from a robust literature of evidence and science that pushed to better medicine. And though it's been a long journey over 5 years, the outcomes are so much better that when we've compared our numbers, to give you an example, we're seeing patients that are almost 2 to 3 times sicker than when the program started, where we've reduced our blood utilization to numbers that are highest across the world, and we still maintain the same level of great outcomes in our hospital. If blood was such a big deal as far as determining who makes it and who doesn't, we should have seen those numbers go down and see that we were hurting people. In reality, they're going in the opposite direction. So it is centers like this that shine light on other centers, and as the experience spreads, you start seeing other people pick this experience and then translate it into their centers, and it's quite encouraging and actually uplifting to see this trickle down not only to Prescott, but abroad.
Thank you. Well, that's all the questions that we have. We're a few minutes early. If anybody in the audience would like to ask a question, you can. You're just going to have to speak very loudly so that we can hear you. Does anybody have any questions? Out there.
Do you think there will be a time when blood centers such as the American Red Cross will advocate this?
That's an interesting question. The question was, do you think there would be a time when centers such as like the American Red Cross would advocate it? And there are societies, there's the AABB, which is the American Association of Blood Banking, American Red Cross, as well as numerous other not-for-profit and for-profit entities. Obviously, the less blood we use for those people who make money on supplying blood and getting it for free, since it's all donor blood, it's a great racket. I wish I could get something for free and sell it really expensive. But anyway, we're seeing throughout the United States that the demand for blood is going down. I think, I think that's a good question. I haven't seen a whole lot of advocacy from things like the American Red Cross, but things like the American Association of Blood Banking do have their own patient blood management penchant. Nevertheless, by far in a way, the most aggressive not-for-profit to advance this is the Society for the Advancement of Blood Management. You can look at it on any computer, sabm.org. You can find all kinds of things answered there. So does anybody else want to add to that? Yeah.
I could add to that the AABB model of PBM is product focused. It's about product utilization, whereas PBM, as we practice it and as SABM practices it, is patient-centered. It's looking at the patient, not looking at product usage. We know and believe that looking at the patient is superior to just counting utilization rates.
Any other questions? Yes, ma'am.
You've addressed the resistance of the medical culture in changing toward PBM. Do you see any of the PBM information starting into any of the medical schools?
That's a good question. So the question is, it's difficult to change the culture, and is there teachings in medical schools in regards to patient blood management? And unfortunately, there's still very few hours of teaching in patient blood management. When residents learn about blood, they learn about the blood types, they learn about the risks of blood, et cetera, but they really don't spend a whole lot of time on patient blood management in and of itself, the whole continuum. So there is a push, though, by societies to increase the amount of time devoted to teaching medical schools, teaching medical students right from the time of medical school, but that's happening, it's just not very fast.
Yeah, I think in that regard, you gotta perhaps clarify a little. Medical school is about learning what's normal and sort of the basics of disease in a very basic understanding of how to treat it. It isn't until you go to the post-grad training or the residency program where you learn how to treat things. Right now, I can tell you we're in a transition where 5 years ago, a lot of the societies would recommend transfusions just to even resuscitate people with low blood pressure. In 5 years, I've seen a lot of that not only change, but go away in the opposite direction. So for some of the residencies and fellowships that are associated to PBM programs, they do get a little bit of that training. For the kids that come and spend time with us, they do get that training, but it's by no means overwhelming or enough to account for all the number of schools and programs out there, I think.
Yes, sir.
Putting it in simple terms, since things are scientific in medical treatment and studies, could there be any simplified evidence that's obvious and
So you're making an assumption that surgeons and doctors are high in intelligence, I take it. Okay. So this is the simplest way that I've found to put it. And this, you know, people can understand this, whether you're a layperson, a physician, a surgeon, what have you. So normal heart function is measured in an ejection fraction. And normal ejection fraction is 60%, but your heart can go down to 30%, and you can still do pretty much everything that you need to do. If you have a cancer in one lung, and you need to have that entire lung removed, as long as the other lung is normal, you can have perfectly normal functional capacity. You all know that you can donate a kidney and not need dialysis because your other kidney will take over the work of those. So we all know people who have half a brain and still function relatively normal. My point is that our human body is an amazing structure, and it has the capacity to work. Really, we've got twice as much as we need to work. And a normal hemoglobin is about 14. So you would think that half that hemoglobin of 7, which is actually what we call a trigger point when blood may become necessary, but so a hemoglobin of 7 is relatively perfectly functional as long as you're not going to lose a lot during surgery. And certainly with the idea that your bone marrow can, especially with the proper type of encouragement, can bring your hemoglobin back up to a normal level at a particular time. That is the simplest way that I can put it. And I'm not sure that that answers your question, but you know, if they don't understand that, you know, then they have a mindset that they're not going to, they're just not going to accept this. But like was mentioned, I think, by Larry Burns, there are thousands of good scientific peer-reviewed articles that show that blood conserving blood or not giving blood is at the very least as good as if you were to give blood, meaning it's non-inferior, and yet you're saving a valuable resource and saving and you have financial savings with that. Many of those papers show that there's a benefit to not giving blood. There's maybe one in the entire literature, and we're talking thousands, there's maybe 1 or 2 studies ever published that show that patients that get blood in an appropriately matched study do better. So the evidence is overwhelming, and sometimes it takes a long time to achieve a paradigm shift.
Well, and if I can tell you, like, what was the actual history of this program, it didn't start by coercing everybody and say, hey, listen, Peter and I got together and this is how we're going to do it. It actually came over people realizing that I was taking care of patients just like Peter with really low blood counts. You've met some of them today. And all of a sudden, colleagues would wonder, okay, you didn't send this one to hospice. What do you mean this guy actually walked out? What do you mean? And all of a sudden, that bug started to stay there. I have not seen anybody turn over the evidence, which is what I would expect. I've seen them turn when they saw it with their own eyes. And I think that is what, you can call it word of mouth, if you will. It takes longer, but the change is more permanent. And what we've seen here over 5 years is pretty much most of the staff in the hospital has made that transition, not because it was forced upon, but they've had themselves directly or indirectly been witnesses to good outcomes. In their own, they've then moved to study the science, and then they became open to it, and that leads to further success stories, and I'll tell you more later.
Question.
What should I say when United Blood Services calls me up and say, we need you to donate a pint?
Blood saves lives, okay? It does. Many of our servicemen in the wars have survived because they were able to get a blood transfusion. The deal is that blood has risks, and you only should get blood if the benefits of getting that unit of blood outweigh the risks. So you should give blood if you can. It's one of the most humanitarian things we can do. In fact, after 9/11, there was a tremendous outpouring of humanitarian aid, and people gave tons and tons of blood, and 95% of that blood was actually wasted because there was just too much blood, and there was no. But blood does save lives. We don't want you to go away from here thinking that you should never ever get a unit of blood unless you have your own personal reasons for not getting a unit of blood. But that's what I can tell you. So if they want to, you should say that you should get more than orange juice. That's what you should tell them. They're selling. I mean, yeah, they've got business to run, but they're getting their raw product for nothing. So, but and the reasons for donor blood is obviously because there are obvious reasons for that, and that's the way it should be. I think we have time for one or two more questions. Yes, sir?
How is the PBM program addressing the complications with the use of blood thinners?
How is the PBM program addressing the complications of blood thinners?
So there are a number of new medications that have come on the market that we use at our blood thinners. Obviously, if you're going to be evaluated for a surgical procedure, part of that evaluation is the medication history and the tendency to bleed. Those agents are going to cause you to bleed. So we have mechanisms and ways to get you off that medication, transition you to a temporary medication until you go to surgery, and that will clear out of your system so it decreases the risk for bleeding. So you can discuss that with your doctor, and they should know that. And you don't want to have to go to a procedure electively. Obviously, if it's an emergency, we have to do what we have to do. But if you're having an elective procedure, you want to be off that medication.
We have many tricks up our sleeves. We have machines that measure different parts of the clotting cascade. We have medications that will reverse whatever medication you're on, et cetera. But like Tony said, it's important to let your physician know everything that you're on. Even though if it's not a prescription medicine, it still can be harmful. I think we've got one more question if there is one. Yes, ma'am. Dale?
We're the only one. There are, when we say PBM, we
say... In Arizona.
In Arizona. Yeah. That was your question, right? The PBM program is an affiliation of doctors and professionals within a given hospital system. There used to be a program in Phoenix, I think many of you are aware of Banner, but that's not a program anymore. There are still remnants of it, like disparate elements, individual doctors who practice it, but they don't have colleagues necessarily that are networking with them to provide a beginning to end patient care. That's why a program such as we have here at Yavapai has a superiority in that we have a team. Not to say that you shouldn't go to skilled doctors in the valley who practice this. They can do it, and they can do a wonderful job. But a program is unique. It's not an individual, it's a system.
Nothing that we do is extremely difficult. It's just paying attention to detail and having all of the pieces in place so that we can take care of patients in the best way possible. So I think it's about time. I want to first of all say that what drives us too is a community that supports us and supports the things that we're trying to do in this. It's a relatively small hospital. Now, 10 years ago, I left an academic center, and to tell you the truth, I was a there were many good reasons to come to Prescott, but I was kind of concerned that I would lose my, academic interest and intellectual curiosity and not be on the cutting edge anymore, no pun intended. But through this program, and this is what we did in Phoenix at Banner Good Samos, we brought this here and we've had the support and the buy-in from everybody here, and it's really put Yavapai Regional Medical Center, everybody's efforts on the map as a model program, especially when it comes to patient blood management. So, we thank you, the community, for being part of that as well. So I hope we appreciate your time, and we hope we've been able to pay you back for your time by giving you an educational, informative, excuse me, an interesting program. So, thank you. Nice meeting you.